क्लास टाकायची. पीरियडसाठी लिहून देते लावायला. तिथे लावते. मला लावायची आहे सध्या. थोडं 7 दिवस.
Very good evening.
Matin sir.
Should I begin? Yes. Very good evening.
Pallavi madam, मला co-host करून द्या जरा.
Yes sir. Yes sir.
Very good evening all. On this eve of this 16/7/2024, we are having 5th session of Protocols of Pediatrics, which is and now for today's session we are having a special topic of status epilepticus, and our expert is Dr. Mahesh Sale sir. I would like to request Dr. President sir, Dr. Ram Gopal sir, to please give his words of wisdom.
Thanks, Matin. Good evening, friends. Welcome to one more episode of Protocol in Pediatrics. Discuss what are the protocols to be followed in a particular case. So once we decided the topic that this time we will cover the neurological topic, that is status epilepticus, as our secretary and Matin suggested. And even I am meeting first time to Dr. Mahesh Sale. So we welcome Dr. Mahesh Sale from Sangli. He is a pediatric neurologist. Welcome, sir. And as you know, sir has already declared, sir is going to give the tips, and we would be sending the PDF file also. You can place that in your intensive care unit, and you can use those protocols. So once again, thank you, Matin. You can take the further proceedings.
Yes, sir. I'd like to request our mitochondria, source of energy and enthusiasm, Dr. Amol Pawar sir, who is the joint national coordinator and secretary general of MAHA-IAP, to say few important words, please, sir.
Thank you, Dr. Matin. First of all, welcome to expert Dr. Mahesh Sale sir, Dr. Ram Gopal sir, then all the Maharashtra IAP members who have joined through Zoom as well as YouTube platform, and all the PG students and all the office bearers of Maharashtra IAP branches, plus the executive board members of Maharashtra IAP. So this is a very nice initiative, well conceptualized by Dr. Bhavish Mithya sir, our scientific convener, that and Dr. Ram sir, that protocols need to be revised, and they need to be revised time to time. So we are having galaxy of experts across Maharashtra, and these people are guiding us since many years, and now they are guiding all the Maharashtra IAP members. So if we follow the protocol, the child will be treated ethically, and there will be no any emergencies. Means if we unfollow the protocols, there will be a deterioration in child's health. So we don't want that, and so these protocols are very basics of our individual setup or any corporate setup or any PSU. So today we are blessed with Dr. Mahesh Sale, who is pediatric neurologist from Sangli, and he will be enlightening us on status epilepticus. So I wish all the delegates happy learning, and over to you, Matin.
Yes, thank you so much, sir. So to begin with, I would like to introduce Dr. Mahesh Sale sir, one of my good friends. He's a pediatric neurologist available in Sangli, and Mahesh Sale sir has done his MBBS, DCH and DNB. He is a fellow in pediatric epilepsy and neurology. He also has a certified course in medical genetics. He's a senior pediatric neurologist working since 14 years. And also he is a vice president of Academy of Pediatric Neurology of Maharashtra State since 2022. Sir is the director of Aditya Rainbow Super Specialty Children Hospital since July 2017. He is a trustee of Sukhayu NGO, which is specially for special kids at Sangli. Sir has various publication and research work. He is a very active member in IAP and in Academy of Pediatric Neurology. And even he is active in IMA also. And sir is a member of International Child Neurology Association and Association of Child Neurology. He is also is a member of IAP Cerebral Palsy, Rotary member, and also sir is recently a member of European Child Neurology Society. With this short few words, I would like to request Dr. Mahesh Sale sir to please and enlighten us with the status epilepticus and also and tell us regarding the guidelines. Please, sir.
Yes. Thank you, all the dignitaries, respectable President, Secretary, and the dear Matin. And thanks for giving me chance on this such a platform for PG student. And that is very important to revise the guidelines. And I'm very delighted. Am I audible?
Yes,
Yes, yes, sir.
Yes.
Audible, sir.
So shall I share the screen? Shall I start?
Yes, 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 you can start.
Okay.
Please start the session.
Yes. Okay, so for every pediatrician, this is very important topic. I'll say, uh, we have seen the emergencies, but this is emergency. We say it's a protocolized since so many years, but still it get unprotocolized while working. That is very practical things I like to say. So I'll start with the what is status. So most of the people maybe that old guidelines, new guidelines, but these are the what I'm giving the slides. These are the all have the definitely protocols from ILE guidelines, IEP books, and some neurology books. These are well published all over the world. So this is the most frequent neurological emergency. 1.3 minimum or maximum 70% epileptic children, they have the status epilepticus at some point in their life. That is very important. Definition, we know the definition that we have the epilepsy patients and this thing. So this is definition as epileptic seizure that is so frequent, repeated or prolonged. So we are only thinking about the prolonged or the myoclonic other children, they have the repetitions also. So to create a fixed and lasting condition. So this is ILE, WHO is saying worldwide. Definitions like if,
हेलो
yes,
हाँ
Please.
सर सॉरी मैं बोला ना वो डैडी एडमिट थे तो 2-3 दिन में
Yes, please continue, sir.
Please continue, sir. Please continue.
Continue,
yes.
sir.
So currently accepted guidelines only two very important ICU purpose. That first is what we are trusting since so many years. If convulsion lasting more than 30 minutes longer or repeating convulsions without recovering consciousness, means patient is drowsy to unconscious. Then another guidelines, practically what we should use, like the American and European NICE guidelines, the practical term, any child arriving in emergency room seizuring should be considered in status. For Sangli and periphery, this is, I think, definition is applicable. Because patient is coming from the periphery, I don't know status of the roads, vehicles, so it takes times more than 15 minutes. And treatment of most the seizure need to be instituted after more than 5 minutes of seizure activity. I'll say if we have the repeated convulsion, it should be also the instituted. So instituted means we should have the proper drugs protocol and we should be ready with the emergency room and drugs. It is more common in children than adult. And no sexual predominance. Male and female children, they are equally predominance. So classification, we have generalized and partial to easy ILE classification. And generalized, we have again convulsive means we can see those convulsions. Non-convulsive means patient has twilight state and but we not able to see the movement, physical movement. So convulsive, we know the tonic-clonic movement, tonic-clonic, myoclonic. We should know the history-wise what is this actually movement. Non-convulsive, we previously say absence or tonic. Why? These are most time the missed. Patient has only some motor arrest like state or twilight state. So these are the things. Partial may be convulsive, non-convulsive. And partial, they have the simple and the complex. That simple we all know without loss of consciousness. And the complex is with the loss of consciousness. So important is non-convulsive status. What is this? It is mostly referred to the partial or the absence seizures. Most of the history, we are missing the partial and sometimes we are missing the epilepsy also. They produce continuous or fluctuating epileptic twilight state. Mother parents saying ki my child is looking somewhere else, and he's not doing any activity or motor arrest like state. So twilight, maybe he can look, he can smile, but he's different behavior. So we have seen the behavioral changes patients also non-convulsive. May involve motor function like epilepsy partialis continue. I have patient recently, sensory symptoms or focal impairment of function, aphasia not associated with alter consciousness. EPC means patient is awake, he is moving movement, and that my patient last week they saying ki, that patient child himself saying my hand is moving since 2 days day and night. Then parent come, they feel that he is doing purposely, but that is actually the awake status. So it is EPC, maybe autoimmune phenomenon. Etiology, so mostly 50% status epilepticus is the patient first seizures. 50% I am saying, this is very proved data. IEP also covered that. 25% are the idiopathic, 25% are idiopathic with fever, 25% underlying congenital or developmental neurological abnormality or history of acquired CNS insult. 25% is the acute CNS insult. So what is acute CNS insult is this list, what we see commonly. Meningitis, encephalitis, metabolic abnormality, most is hypoglycemia we see, and hypocalcemia. Hyponatremia is also there. Head trauma, stroke, drug intoxication, bleed, pyridoxine is also very common. In a non-epileptic, it can be precipitated by withdrawal of the anticonvulsant. That is what I am seeing in the patients of epilepsy syndrome. They suddenly stop the drugs, combination of drugs, and they present with the status. Then sleep deprivation. The international guidelines for ILE, they have given that everybody should sleep before 10. I think doctor is exclusion. We worked all the time. And why? Our pathway dopamine or the serotonin, they affect the brain. Sleep deprivation precipitate the epilepsy or status also. Then intercurrent infections, and now overuse of gadgets. Is it really mobile and TV? They are giving the status episode once in a life in 50% patient. Yes, definitely. Photic epilepsy is the concept, electromagnetic. Respected Dr. Udani sir is working on that, and now it's get common. We getting the patient while watching TV, mobile, he get convulsions and status episodes. So we need to be research at multiple level, multicentric level, then it get proved. And then what is prognosis of this? It varies according to the age, underlying cause, duration. Younger the patient, more chances of long-term neurological sequelae. And in 30%, chronic seizure disorder develop. The status 30%. So that is the big chunk. They can develop the seizure disorders. Febrile seizures, status epilepticus is different entity, what we said. But definitely when there is a status, you need to rule out the underlying causes. Why? Because it can develop the chronic seizure disorder. Mortality rate come down to 3 to 6% because of availability of ICU since 1990. Underlying causes of the status and not the status itself is the cause of death. This is very important. There is some reason that can, suppose patient is known case of heart disease, asthma or anything, that can create a problem. It's not status, never create a problem. So neurological sequelae, everybody knows. Intellectual disability, what everybody is thinking, parents and doctors. Behavioral disorder, focal motor deficit, chronic epilepsy. So these are the important points. Now we'll turn to the pathophysiology of status. We know what I talked is everybody knows. Something very interesting, pathophysiology of the status epilepticus. What actually happens when patient is going into status epilepticus or the inactive status epilepticus is basically what happened. It's a failure of mechanism that abort the seizures. So what we learned is excitatory and inhibitory neurotransmitter. So excitatory neurotransmitter, they increases glutamate, aspartate, acetylcholine. Inhibitory neurotransmitter, they lost the control. So in the absence of that, the convulsion may present, especially in the infantile group, and excitatory especially above the infantile. And then what actually happened in first are the blockade of NMDA channels by magnesium. It causes sodium and calcium influx into the flood to the cells. So there are so much flood and it causes cascade of cytotoxic events and leading to the neuronal injury. So cell lysis and death. This is happen in the status, but it is reversible in first R. That is very important. That's why we have the guidelines to control the convulsions for status because it is reversible. Neuroprotective heat shock protein. This is action is very important. Then prolonged seizures can cause hypoxia, hypotension, acidosis, hyperpyrexia, exacerbate neuronal damage. Okay. Now systemic complications. We have 8 complications. One by one we learn. First is hyperthermia is very important. That is point I think most of the time is missed in elderly children or the infantile children. Definitely very important. The temperature decreases, the patient become again problematic. So hyperthermia, it increases body metabolic demands and oxygen need, result in sustained motor activity, contribute to rhabdomyolysis and sustained myoglobinuria. And after hyperthermia, patient went into hypothermia. So it should be euthermia, what we said. So definitely, while status somebody has to be sponging, these are the European guidelines. The sisters, nursing care is also important. We give the injection, antipyretic injections are well available during those days. Cardiovascular, this is very important. We are getting problem because of change in cardiovascular system. Cardiovascular system what increases catecholamine result in prominent vasoconstrictions. So status, these are electrical bombardment. So it giving the high amount of catecholamine release. Increases in there is increase in pulmonary, systemic, and left atrial hypertension is responsible for 50% drop in cardiac output in first 5 to 10 minutes. That's why the most of the convulsions body prevent it mechanism. The body, brain, all the mechanism cardiac, they try to seize the convulsions in first 5 to 10 minutes. That is what ideally happen. If something get loose, then if it is increases, that's what I'm saying. There is the cardiac output adjustment, left atrial pressure, hypertension, and we may lead to the cardiac arrest also. Second, pulmonary left atrial pressure returns to normal after 15 to 30 minutes. And systemic atrial pressure take times of 60 minutes. See, these are the time need to settle down the heart. So that is very important to monitor. The 61st 1 hour is very important. Reversible, that's why discussing reversible. That's why we need to monitor. And monitoring is very important in first hour. If status prolonged, cardiac failure may occur with a fall in cardiac output or drop in systemic blood pressure. So first hour is very important. Another, hypotension. It's happens some patient hypotension causes decreased cerebral blood flow, which in presence of increased neuronal metabolic rate may result in the cellular death and permanent neurological sequelae can happen. Cardiac arrhythmias also happens. These happens most of the patients. Some of the patients, 1 in 10,000, they dies in convulsions because of cardiac arrhythmia, and especially happen to the pediatric patient. Then again, systemic complication, hypoxia is very, very, very important. This hypoxia can create a trouble. This is troubleshooter as anytime. So hypoxia, hypoventilation, apnea, hyperventilation, chine-stroke respiration, increased oral bronchial secretion, aspiration, pulmonary congestion can occur. So because of this, we need to take care of all those things. And sometime aggregation by the anti-epileptics drugs also. This is very known. Hypoxia can create a problem to hippocampus and cerebellum. We had the patient's status and later 1, 2, 3 years, then again status or convulsions. After doing MRI, come to know the MTS, hippocampal sclerosis or cerebellar atrophy or cerebellar infarcts, galactic lesion. This is often happens because of the hypoxia. Why? Cerebellum, is the most affinity for the oxygen, cerebellum, in pediatric age group. So that's why hypoxia common at the cerebellum, basal ganglia, hippocampus. Hypoxia markedly increase risk of mortality in status. Why? It's increase time, increase hypoxia, increase the neuronal death, so increase the damage over the cerebellum, basal ganglia, and the maybe increase to the other parts, occipital area, parietal area. These are the sequential areas. Seizures without hypoxia are much less dangerous than the seizures with hypoxia. This is very important. Acidosis, most of the time status, we pediatrician need to take care of acidosis. Most of the pediatrician always taking care. We need to do the ABGs. Acidosis, they are the more risk of the brain damage or the cardiac problems or the long-term other system problems. So taking care of acidosis is also important. So ICU patient is status, stop, 1 hour monitoring, go for the ABGs and other things also. Very important, hypoglycemia to monitor. Whenever patients come, we do the glucometer monitoring. Then another 30 minutes you go for it, and after seize of the status, 1 hour, you definitely check the glucose level. Hypoglycemia occur after 30 minutes is very important. Hyperglycemia occurs initially because of the high epinephrine levels, and then hypoglycemia occurs 30 minutes. These are the mechanisms. Then cerebral blood flow and intracranial pressure. This is again very important. What is the ILE? The research has proved there is a increased cerebral flow 200 to 1600 times percent above the normal. That is the problem in status. So we have to take care. But brain flow system, arterial system is very compactable system. So it's very rarely in pediatric patient to have the bleeding status. It's very rare. It happens, but it's rare. The increased cerebral perfusion pressure persists for 40 minutes and returns to normal. And there is only brief rise in 7 to 20 mm of Hg in ICP, intracranial pressure. And by the end of 15 minutes, it returned to normal. So brain itself try to return in the 10 to 15 minutes to the normal by keeping it, then cardiac system, then other system. So 1 hour monitoring is still important. Hyperkalemia, this is very, very, very important. Arrhythmia and cardiac arrest are common in the some hyperkalemic children. Patient who usually dehydrate in convulsing high acidosis can causes hyperkalemia. That is common experience in the ICUs. Myoglobinuria, very important. Renal failure or rhabdomyolysis can cause because of the myoglobinuria. This is the X-ray, our patient who I lost in the status, this patient, because it's a learning lesson. This is pulmonary edema that patient has suffered. Everything controlled, and then patient developed pulmonary edema and cardiac arrest. And this is learning lesson along back. And this is very, very rare, but we need to look after the chest signs. This is important. Pathophysiology changes, I'll discuss the two changes simultaneously, first 30 minutes and then later. So first 30 minutes is compensatory changes and later is decompensatory. And these are the list. The compensation is like the tachycardia, hypertension, increased cardiac output, PLR, hyperglycemia, increase CVP, increased cerebral blood flow, lactic acidosis, and the salivation in content. These are the compensatory. What we have to see the clinical. Some of the points are clinical, some of the need monitors, and this some other test. And these are possible. And what we see, the fall in cardiac output, hypotension. See, these are the point is very important. If these are there, we desperately need a ICU backup team, very important. Rise in cerebral venous pressure, hypoxia, hypoglycemia. Hypoglycemia is all the time risk factor. Cerebral edema, hyperthermia, metabolic acidosis, hyperkalemia, myoglobinuria, SIDH, and coagulopathy. This is post-COVID, we are getting the patient of coagulopathy. Coagulopathy in these all factors can create a trouble in management of the status epilepticus. So these are the basic pathophysiology. Now, what we have to follow in evaluation in emergency room, this is very important. All the residents, doctors, senior, juniors, this is emergency. If we manage 100 times, but still it is emergency. So senior people, they have the habit of all the monitoring, taking history. This is important. So what description and history is very important. I am saying description, what parenting. We need to give the drug simultaneously, ask the history, surrounding circumstances, preliminary symptoms, progression of clinical patterns, duration of event, post-ictal phase, his incontinence, his tongue bite issues, how he behaves, what type of convulsions, his aura, preceding factor, post-ictal preceding factors. It is very, very, very important. And about of dose, misdose, timing also is very important. In OPD, I always telling mother ki we writing sakali and sandakali, morning and evening, and most of the mother giving at the afternoon, at the lunch time and late dinner time sometime. So what we said, these drugs made it like that. They no need to take the food. You can give directly. This time is very important for the anti-epileptic drugs. So 8 a.m., 8 p.m. and 1 hour, the timing adjustment is okay. Before school is very important. Saturdays, mother saying, no, no, we are giving after the school. No, I'm saying ki patient is going early, give the early medication. This is important. Post-ictal phase monitoring is very, very important because most of the event happens in the post-ictal confusion in that phase. Patient has confusion, hypoglycemia, hypoxia, other psychiatry disorders on anything. Some patients convulsive, they will evolve to the non-convulsive also, status epilepticus. The behavioral changes, but this need the very high suspicion of index. And this definitely required because convulsions, patient don't have convulsions, but there's a monitoring changes or the patient is not improving. We have confidence on that patient, daily looking patient, convulsions. Okay, I'll control in 5-10 minutes or patient will improve in 5-10 minutes, but it's sometimes not happen. So we should be cautious. Investigation that definitely everybody knows CBC. Glucometer is very important. Serum glucose, calcium, magnesium is very important. Is though rare, 1 in 1,000, but hypomagnesemia, familial disease is very common. Electrolyte, you go for it. Don't hesitate. Sodium, potassium is very important. See, most of the thinking potassium, why potassium? That is, I'm saying hyperkalemia monitoring is very important. Arterial blood gas, level 3 ICU, they covers all those things. Blood urea, creatinine. Why? The status sometime we should know the initial status of the patient's kidney and liver. Why liver? Most of the drugs, they are going to liver and sometime myoglobinuria happens, they can damage the kidney. So both the way is the status and is the drug. So we should know the RFT and LFT is very well. Anticonvulsant medication level available, required in emergency, we can do later also, but available, you can go for it. Lumbar puncture, if suspected for meningitis, doubtful, go for it. What we learn from our seniors, and we are also telling our student and juniors that you doubtful, you go for it. Don't hesitate. Fever and if you thinking suspicion, go for it. Because this is treatable entity worldwide. Treatment should start even without ELP if suspicion on meningitis. Most of the periphery parents, they don't give consent of doing ELP. So most of we also learned to give them. So we start with the higher antibiotic or meningitic doses initially. And then we see the scenario, we try to convince the parents. And if we need a high indication of meningitis, then we should convince the parent. Then next investigation, not in emergency, what I am saying, MRI is very, very, very beneficial. So I'll take 1 minute on MRI. Why MRI? MRI is MRI shows the good differentiation of gray matter, white matter, areas, even sulci, gyras, and other differentiation. Now we have the good machines, 3 Tesla machine, 3D machine, 1.5. What is the guideline, national, international? It should be at least 1.5 Tesla above MRI machine to do the MRI of the pediatric age group. Why pediatric age group? Because pediatric brain, growing brain, myelination issues, differentiation issues, Salkai Gaira, dysplasia nowadays, dysplasia giving the status, most of things, and inversion of hippocampus, all those these things we can find in the more than 1 Tesla machines. And definitely MRI, instead of doing the plain MRI, you should go for the epilepsy protocol. You should go for the 3D or dysplasia protocol. If you are doing MRI, go for it. Why? Plain MRI, sometimes software is not applied, it means the dysplasia. Epilepsy protocol, sometimes it means the mesial temporal sclerosis or hippocampal pathology. This is the commonest pathology in the adult age group, temporal. So MRI, doing MRI, this protocol should be this thing. But CT scan, why not CT scan? If emergency in trauma, malignancy, persistent headache, new focal CNS signs, we should go for it. Why? CT scan. CT scan is the 5-minute technology and most of the available in multiple areas in multiple cities. So that is important. MRI, mostly 2-3 areas in the city. CT scan is available most of the in sometime hospital, indoor facility. We can go for it, but only issue of radiation. MRI is magnetic. You do multiple time, no radiation issue. EEG, definitely EEG. In the level 3 or well developed, they do the ictal EEGs, or nowadays, if you can send the patient once get control for EEG, it's not need to wait for the 2 days, 3 days, or 4 days to send for EEG. New machines, digital EEG, they picked up the ictal phenomena. Means during convulsions, we are doing EEGs. And then post-ictal also we are doing EEGs to look to rule out the non-convulsive status epilepticus. All patients with refractory SC should have continuous EEG monitoring. That is very, very important. Then management of the acute seizure, very important. I'll tell you 4 things: maintenance of ABG, institution of drug therapy, that is the guidelines and chart what we are using for the status, then diagnosis of the cause for the condition. Till then, the wise pediatrician doctor should know the provisional diagnosis, what actually we are dealing with. For example, the patient of the known case of the some brain trauma, post-hypoxia, post-hypoglycemia sequelae, neurodegenerative disorder, trauma. Patient has trauma and we are behind only stopping convulsion. We have to look up to the other things also. And prevention of further convulsions is very important. Team approach. Now it start the team approach. Team approach means doctor, then you should have the another doctor, sisters, and the intensivist sometimes is very important. What is the stage first? Stabilize the patient. Airway, breathing, circulation. That is why I learned from the IEP is very good in that. And the most of the pediatrician very good in that. The first step of management before attempting top seizure is first apply the oxygen supply. Oxygenation is very important. Oxygen for the brain, cardiac, everywhere is oxygen is very important. So start minimum 2 liter oxygen is very important. So start with the oxygenation. Then airway, patency, position, oxygen by nasal cannula or non-rebreathing mask. Monitor adequacy of the ventilation, oxygenation, and be prepared for the intubation. Rapid sequence of intubation be used, protect from the injuries. So team approach means you should be ready with the all those things, instrument or intubation materials or the instrument should be ready. Monitor. Definitely monitoring is very important. We'll go the drug guidelines after this finishing. So monitoring is cardiorespiratory monitoring. This all those rates, cyanosis, SpO2, blood pressure, ECG. Apply the ECG leads in pediatric. Most of the time we are not applying, childrens are not that this thing, but we need to apply the ECG leads, and monitoring of the cardiac is very important. Put the monitor on the lead 2, and it's very important. Sometimes the heart rate is very important in those things. Establish intravenous access is very important, 1 or 2 access. So it's very important. Because sometimes it is very difficult to put the another cath after 30 minutes or 1. So obtain blood samples, if possible, applying the second cath. And hypoglycemia. First thing is to go for the glucometer, and if it is hypoglycemia, treat the hypoglycemia. Hypotension is very, very, very important. Hyperthermia. And simultaneously anticonvulsants drugs. So what is stage 1 protocol? Stage 1 protocol, we have the 3 drugs: lorazepam, midazolam, diazepam. Diazepam mostly now new generation not using. I am the from borderline of the old and new generation, and so I have experience of diazepam long back, but I am not used since last 10 years. Lorazepam we are using, midazolam we are using. Midazolam we are using very commonly as comparison with the lorazepam. I have equal clinical experience of lorazepam, midazolam, but midazolam is more commonly available than the lorazepam. What is my observation in periphery? So I think we are using more midazolam. Stage 2 protocol 10 to 10 minutes, that is therapeutic endpoint cessation of clinical and EEG seizures. Several drugs are effective. Then timing, route, adequate doses of medications, and that is important. Choice of drug is important. We'll discuss the drugs. Then most common mistakes made in the treatment of ESC are administration of inadequate doses. Patient is bad, we should give the 10 milligram per kg instead of 20. Don't do that, because 10 or 20 is going to be same effect in the patient. Patient is adjusted. So don't give the inadequate doses. Use of the short acting agent only. Some if I after giving midazolam, the convulsion ceases, but we need to give the proper anti-epileptic. These are a short acting. We have to give the long acting simultaneously. So after giving midazolam, try to give the proper anti-epileptic drugs. Early effective treatment is essential to prevent morbidity, mortality. On longer duration of seizure episodes before treatment, more difficult to stop and greater risk of long-term neurology sequelae. So protocol of anticonvulsant is very important. Every institute had his own protocol. In India, we are differs in protocol. Chennai guidelines different, North different, Maharashtra, we are accepting everywhere's guideline. I went to that Meghalaya, they are using their deficiency in the availability drug, so they are using the old drugs again. So, but still is okay. So you can, but your institute had that guidelines. Anticonvulsant drugs, so we'll discuss benzodiazepines, what we discuss, lorazepam, midazolam. These are very commonly available. Midazolam experience being a pediatric neurologist is very simplified. Don't have the complication later and don't have the monitoring if you are giving the more than 2 or 3 doses also. So these are the diazepam, lorazepam, highly lipid soluble diazepam and a less lipid lorazepam. Anti-epileptic will last for 20-30 minutes and lorazepam 3 minutes. Diazepam doses is the 0.3, is the doses are same everywhere, 0.1 to 0.3 milligram per kg. And C, diazepam only importance giving rectally. Lorazepam also we tried rectally, but less effective. And what we new invention is midazolam nasal spray also. So midazolam available in IV and nasal spray. Compared to previous drug, it is very less lipid soluble and the medium time control is 2 to 3 minutes. See, the time is very important. Shock acting AED effect lasts for 4 to 5 hours and dose is very good dose, 0.1 milligram per kg to the 0.5 milligram per kg, maximum 4 milligram. See, maximum 4 milligram, what I written. Why? After 4 milligram, we need to monitoring the respiratory issues or the cardiac issues sometime. Can repeat after 5 to 7 minutes. Why is action this thing? And we can give the 3 doses of midazolam. What is personal experience of mine in during residency or still the now we are doing. Second drugs, what to use? That is very important nowadays. So according to patient, for example, my patient having the febrile status epilepticus, and we can use sodium valproate. And once we use sodium valproate, and then we come to know liver enzyme increases. It happens sometimes. We know the status, and post COVID, we are getting patient like that. So it is safer to give the simplified drugs, either fosphenytoin, either levetiracetam. But our guidelines, drug of choice, fosphenytoin. Why? Phenytoin and fosphenytoin, 2 drugs are available. Old school phenytoin, new school fosphenytoin. We prefer fosphenytoin. Why? It's a water soluble in comparison with the phenytoin is the oil based lipid soluble, and the long acting AED both are and can be given. This fosphenytoin beauty is given, can give the IM also in emergencies. Cath is not applicable. We can give the IM to the thigh region and very useful. I tried 10 to 12 times and this is useful. Phlebitis and soft tissue damage is very less compared with the phenytoin. We have all experience of that. So fosphenytoin water base is always preferred in comparison with the phenytoin. If it is not available fosphenytoin, you can use the phenytoin. Phenobarbital is the long-acting AED, but should be given cautiously. Very fast giving, very high doses can cause the respiratory depression. So break the doses. 20, 10, 10 is that is we are following. And the peak level is 20 to 60 minutes. See, that is the peak level. And after that peak level, patient become drowsy or sleepiness. That is also issue with the phenobarbital. But don't forget the pulmonary edema. That is very important. Levetiracetam, that is beauty of the drugs, new drugs. Nowadays getting the first line drugs. And we are telling use doses, more doses, 20 to 30 milligram. I'm personally using the 30 milligram doses for the infantile also or the elder group also. And it is very easy to give. We can give 1:1 dilution and give to the directly or infusion also. And we can give in 10 minutes or in 5 minutes also. It is not the hazardous drugs. Very good drugs. It should be available out the periphery without hesitations. But drug itself has a limitations. Levetiracetam, what we observe is the good in neonatal age group. Then from neonate to infant is less effective, and from 2 years to above is also effective. Don't know. This is because of the, I think, channels or the receptors, or maybe these are the experience. Lot of study is in ILE website, but levetiracetam is worldwide accepted. Why? We can accept the some psychological psychiatry side effect in comparison with the some organic complications. So that's why drug has become famous. Then everybody's favorite is the old school, new school drug, sodium valproate. It's freely available in India. Compared to other developed countries, they ban these drugs. And we should use 20 milligram per kg. And if seizure persists, we can give additional dose of the 10 milligram per kg. And like this, we can go up till 40 milligram. And the administration, 1:1 is very important. You can give directly, very slow in emergency, but monitoring very slowly, I'm saying. You can take a 10-minute or 15-minute. And there is a maintenance doses. Again, you can give 15 to 20 milligram per kg per day. BID doses, what we prefer, or sometime TDS in the children less than 1 year. Many trials with good results. This is very lovely drugs. What we say, pediatricians drugs are not approved by the US FDA for treating SE in intravenous continuous drips. That is what I found most of the journals. Why US has not approved? Because Asian countries we are using like anything. This is again new drugs, lacosamide. Still pipeline drugs, we can say it is the old drug, and but they're using in the adult is used by the adult neurologist. But lacosamide is good in pediatric also. My personal experience since last 10 years, and I was in the trial of lacosamide in pediatric long back, and very good drugs we are using, and most of the status, most means not all the, but most of the status they get seizures after lacosamide. This is focal drug of choice. 5 milligram per kg dose that we can use. We can give two doses at the interval of the, you can say, 20 minutes. And the maintenance dose is same, 5 milligram per kg per dose. It is the water soluble, available 1 ml to 10 milligram preparation. The vial comes with the 10 ml, and 1:1 or 1:2 dilution we can give. And there's very good drugs. If patient don't have underlying cardiac condition, we can give the intravenous slowly. And if it's a known cardiac case, then you have to take care of lacosamide, you have to take care of the phenytoin, you have to take care of the phenobarbital. Three drugs are very important. If your patient has underlying cardiac, it's very safe to give levetiracetam, very safe to give most of the time sodium valproate also. Cause emergency, they don't have complications. Most centers start with this midazolam, lorazepam, and the infusion. What we give, the don't want hypotension, we start with the NS. Phenobarbital prepared in newborn. Domiciliary treatment, we always ask for the status. That is also important. I include this slide purposely for parents. The parents should have the nasal midazolam or lorazepam spray. Midazolam spray every 5 kg, we should give one spray in each nostril. Means 5 kg we can give one spray each nostril, 10 kg 2 spray, 15 kg 3 spray, 20 kg 4 spray. Above 420, you can keep 4 or 5 to spray at the weight up till 50 kg. Adult, above 40 kg, we need 1.25 preparation. And pediatric midazolam, we need 0.5 preparation. This is very important to know. If you are using the higher preparation in pediatric age group, sometimes it will keep the patient drowsy, unconscious for a prolonged period. So this is very important. Beauty of midazolam sometimes is buccal nasal route also. Rectal is also tried. And step 3 is the refractory guidelines, then refractory status epilepticus. And after 60 minutes, we should work on this guidelines. So what we discussing is institution is very important. So stage 1, step 2, and step 3 guidelines is very important. And for step 3, we require PICU guidelines is very important. We need the pediatric neurologist, all the teams is very important. Monitoring. Refractory status is most commonly developed in the presence of acute CNS injury, neurodegenerative diseases, or the brain edema, corticosteroids, other this agent should given. So stage 3 guidelines is what? Midazolam infusion spray. So I'll prepare one good charts, easy for everybody. So I'll give to the Mateen, and Mateen will distribute to all these things, and you can distribute to your all the ICUs. This is very easy chart. This is my own preparation I did. Midazolam, we have experience of many times giving midazolam nowadays, especially post-COVID phase. And what we start with the 0.2 milligram per kg stat. So these charts I made, you can put in ICU. When you start with the 1 to 18 microgram per kg per ml to be titrated seizures, and that is the formula 5 into 8 milligram in 50 ml NS, or the 5% dextrose. Why formula is given? For giving the drugs, this is very important. If we adjust in 25 ml this thing, it is problematic in few hours. So 1 ml per hour is 1.6 microgram per kg per minute, and we can give to the 10 ml per hour. We can give till the 16 microgram per kg per minute, and you start with the 2 ml per hour in status, straightforward. As the convulsions continues, you can increase every 15 minutes, not the every 5 minutes I'm saying. At least a 15 minutes or 15, 30 word guidelines saying 30 minutes, but 15 minutes is sufficient cause we have a good PISO setup nowadays in last 10 years. Monitoring the BP, and when we are giving midazolam, you should watch for the respiratory compromises. You need the backup ventilator plans, and we have mostly 80% patient who need to put on ventilator. Hypotension should monitor. 20% patient require the dopamine, other thing, if they develop the hypotension. These are the ICU reversible backup management, and all the intensives, they're easy in that. If patient not respond to your midazolam drip, then you have to think what is next. This is very important. And the next is the pentothal. That is also good drug, but this is general anesthesia like drugs available. That is also again the need the good team. And while giving pentothal, patient should be intubated first. That is the experience. Pentothal, it's available in 500 vials, 5 milligram per kg IV bolus. We give that infusion. We give 1 to 5 milligram per kg per hour, and slowly withdrawn in 12 to 24 hours. Definitely go for within 24 hours withdrawal. This is very important. After 24 hours, it's very difficult. Patient can die because of the multiple complications also, or the comatose state can prolong. Each is very important in both midazolam and the pentothal. While giving why, we need the where is a break point. Because we are increasing the doses, patient is unconscious, and where is the break point? Break point is the cessation of convulsions. Means patient has the physical convulsion should stop. That is the first point. Or EEG monitoring is required. Up till third stage, EEG is definitely required. Burst suppression pattern should achieved while giving these two drugs. If burst suppression pattern achieved, then we should not increase the drug. Its level should be maintenance, and then we should monitor the patient. Then after 12 to 24 hours, we should start withdrawing the drugs. If patient is improving, monitors everything 8 hours, you should start the changes after 8 hours also. Is very important. And is very best in encephalitis, HI, or the old TB status. And the burst suppression sometimes is very difficult. We require expert, but end point is seizure control is very important. You should know. Intravenous propofol. What is next? Is propofol. High experience of 5 to 6 times of propofol is very general anesthesia, but it requires anesthetist. And the preparation of propofol is slightly tedious. I think pediatrician, most of the don't have experience. And being a neurologist, I had the experience of this, but not much beneficiary in comparison with the pentothal. The adult, they prepare propofol in comparison to pentothal. Why? Pentothal induced coma is very sometimes bad. It requires protocol. Means if we withdraw the pentothal, we need to give the phenobarbital, and then we start to monitoring, and we have to shift the artificial coma and then slowly withdraw. So it required the basically intensivist job. Intravenous propofol is very easy. Bolus of 1 to 3 milligram followed by the infusion, and monitoring convulsion seizures. You withdraw, you can immediately withdraw. This is the very importance. Then suppose convulsion still persist. The last week I stuck in the EPC patient. Then what new? This is the chart. We have the receptors. So these are the drugs where what drugs should give. There are so many drugs. We can't give one by one drugs. So what is next? So after 1 hour, the patient develop the NMDA or the receptor resistant. So topiramate is one of the good drugs. And this experience by the pediatric neurologist most of the time, very good drugs in neonate also we can give, in infant also we can give, and pediatric also. And dose is 5 milligram, 2 to 3 milligram per kg. You can keep increasing 5 to 6 milligram per kg. Till 7 milligram per kg is very okay through DT, RILES 2. And but these drugs require larger trials. Because during status, most of the status stop giving the intravenous, and those are not stop can try the topiramate. So there are no larger trials as taken, multicentric trials. Many trials comparing midazolam on phenobarbital, midazolam with thiopental. There are so many trials in India because India we have good ICU setups. Lidocaine also is trying, is mostly adult people, adult neurologists and physician, they are using the lidocaines. Pediatric lidocaine is hypotension is the problem. And lidocaine sometimes has the irreversible problems also. We have experience of giving lidocaine and patient is not returned back to normal. He become unconscious, ventilated. That is problem. Hypothermia is the new technology, especially for the neonate and infantile age group, to do the hypothermia patient so that we can decrease the brain temperature. Intracerebral artery flow also can be decreased, and so there is a less neuronal damage. That is the hypothermia can cause. And neurosurgery is, we can think if patient is still convulsing 1 day, 2 day now, ventilated, and this thing. So it is important. Is the dysplasia or the any structure change in Salakaga area or any tumor or any hippocampal pathology. And so we definitely require sometimes surgery. So this should know, we should know on these things. So take home message. So before take home message, Mateen, I would like to share the, or I'll discuss the take home message and then we'll share that word file. So go systematic, ABC is very important. Don't take hurdles or don't hurry to manage the status, and don't panic everybody. So it's a teamwork. You are the leader. So what is I am saying you are, if you are team leader, you should be very calm and cool. So that's why your sisters and staff will get calm and cool. Patients, they are panic. Relatives, we are medicals. The most of the non-medicals, they are panic. So don't be panic. The leader should go put the cath, put the oxygen, give the midazolam. This is the doses. Give this. Go slowly. Start this phosphonatine. Another sister put this thing. So you should be a leader, and don't be panic. Cause situation can be managed. This what I'll observe and learn, the situation can be worsened by the panic nature of doctors, sisters, or the relatives most of the time. So status and emergency should be monitored very carefully and try to find out the cause. So you should know the provisional diagnosis, known cases, you should know the important. So we should ask the parents what is the history, then he will say, okay, he has the neurodegenerative disorder, then you should know what is this. Then you can start giving the, after 2, 3 drugs, you can plan the midazolam drip also. That is easy. Benzodiazepines followed by the long anti-epileptic, this is the very important message. Because only giving the midazolam is not sufficient. After giving midazolam state and you are suspecting more than 10-minute convulsion, definitely give the phosphonatine, levetiracetam or sodium valproate. This is important. So I'll escape this. And another, I want to share a screen, this. Okay, so everybody can see these are the status epilepticus. Previously it was 1 page, then 2 page and 3 page. What we written is very everything. We try to write everything from my residency till date, updated. So child, this thing, the drugs, I made the chart. So you can see general measures, ABC. Then emergency investigation mentions CBC, PTA, PTT added because of the post-COVID issues. and monitoring is very important. Then drugs, then stage 1 protocol. See, these are the drugs midazolam preferred, and what preferred 0.2 milligram, 0.1, 0.2, but we give 0.2 milligram in our ICUs. Then stage 2 protocol, that is phenytoin injection come. See, these are the IAP guidelines, ILE guidelines, and WHO, what we prefers commonly in worldwide. So we can follow that. If everybody is happy with phenytoin, they give, but monitoring and extravasation, they should manage. Phosphonatin is very beautiful drug, no side effect. Phenytoin has sometime known case of cardiac, has the sometime cardiac side effect. Phosphonatin has the lesser issues. I don't find any patient of phosphonatin till date. And the WHO guidelines says more prefers the phosphonatin over the phenotines. European guidelines and USA guidelines, USA they available phosphonatin, they withdraw the phenytoin. Australia they prefer phenytoin instead of the phosphonatin. So countrywide there is a differences. Levetiracetam. So I try to put the doses also on examples also. And the phenytoin doses is 20 milligram per kg, then 10 milligram you can give, another 10 milligram, you can reach up to 40, but phenytoin 40 is need daring to give. So 20 and 10 is sufficient. Phosphonatin you go to the 40. Problem of phosphonatin, the ampule written 1 ml contain 1 ml contain 50 milligram phenytoin equivalent and the phosphonatin equivalent. And then what I uh, uh, got from my seniors and I'm giving to my juniors is it is very difficult to calculate according to PE equivalents, phosphonatin equivalents. The bottle written 1 ml 50 iptine units. So calculate according to iptine units. There is no much difference in calculating PE or this thing. So it's easy. For example, 10 kg, 20 milligram per kg is 200. So we need to give the 2 cc because bottle contain 1 ml 50 equivalents of the phenytoin. So it is easy that we should discuss with the our ICU team, sisters and residents, everybody. And then levetiracetam, good drug, 20 to 30 milligram load with, and then you can increase the 10 to 15 milligram again. You can go up till the 40 is written, but in status you can go up till the 60 without hesitation. In the trial, we given up till the 90 without hesitation. But after 60, we develop some the psychological psychiatry behavioral changes. So that's why 60 and for maintenance 40 is very okay. Sodium valproate, very good drug, 20 milligram per kg. You can increase 10 milligram, another 10 milligram, 40. You can go very safely, but definitely go for the LFT. Patient come with, we are sending LFT. Patient asking why? We are saying ki anti-epileptic drugs and this effect we need to monitor. Lacosamide. What we discussed, very good drugs, 5 milligram per kg, no required monitoring. Levetiracetam not required monitoring. Sodium valproate only LFTs. Lacosamide in a known case of heart disease that required it ECG should normal. That's why we are asking put the ECG leads while managing the status. And then come the phenobarbital. So I prepared the drugs according to its the complication effects. Phenobarbital, why I put that? Because sometimes respiratory depressions or comatose state is sometimes difficult to manage at peripheries. But phenobarbital also has good effect in cessation of the convulsions. So these drugs should be at the 3rd place or 4th place in your guidelines. But complication, we should know the complication. We should have the ICU team to manage these complications. Stage 3 protocol, this midazolam we discussed, infusion, then the chart for the pentothal and the propofol. So I think up till this is very easy for the pediatrician and who interested in ICU or intensivist is very important. Monitoring is very important. What we said, ABC, ABC, we should teach the staffs and resident ABC in private and in institutes is very important. Topiramate is the very good drugs we tried. Oxcarbazepine in trials. Oxcarbazepine is the drug for channelopathies. So sometime giving the high doses of oxcarbazepine, 3-4 doses is also is written in the most of the guidelines. In India, we are not using trials and error we are doing. So I think I try to cover the most of the status points. So thank you very much, Matin.
Yes, very thank you, sir. Excellently taken, sir. We have few queries if I'd like to
Yes,
ask you regarding the newer drugs regarding ketamine, isoflurane, the
yes,
doses, and also
yes,
kindly add a note on role of immunotherapy if you think of.
yes, definitely. So while asking history, we should know the stop the convulsions, but these are the drugs. See, these are not anti-epileptic. For example, I'll tell you autoimmune this thing, autoimmune epilepsy is autoimmune. This patient having the history, then only you can try the autoimmune. For example, Rasmussen encephalitis. The giving anti-epileptics equally giving the immunotherapy is important. So what is the drug of immunotherapy? Steroids, IVIG, rituximab. So we are trying commonly. And these are the drugs immunotherapy. Other what drugs you are try to say ketamine, those things. I very less experience, but that is what I'm saying. The trial drug, instituted drugs, safe drug is very important to use. Ketamine has hypertension and other issues and other drugs. But in some diseases we need to give, but that's why we need the history of the patient. Definitely in epilepticus status, we try to give acyclovir also simultaneously. Steroids to prevent the cytotoxic injury is very important. But before that, don't forget to rule out the infection of the patient doing CBC, CRP, all the other things. Procalcitonin is very important.
Few words regarding pyridoxine.
Pyridoxine is very important, especially in NICU. Pyridoxine previously difficult to available. Now it's available in IV form. It's available in tablet form, but not separately. It is combined with the other multivitamin. So definitely read in MVI. Other the tablet, I'm using the tablet of 20 milligram, half tablet. And the ILE guidelines, it always prefer if now breath holding problem is increasing there. Absence problem is increasing. Genetically also, environmental factors also. The ILE says you can try B6 for patient 10 milligram daily for at least 10 days. In emergency status, pyridoxine deficiency, giving IV pyridoxine, it can seizures and we can use very easily. But pyridoxine, giving a pyridoxine, it required cardiac monitoring. It's not that easy. Yes, I experience of twice only pyridoxine, but definitely useful. Yes.
Okay, so few practical questions, sir. Sir, what will you tell regarding the consent? We have to discuss with the parents. What few important words of consent for
Consent,
document?
yes, definitely. I'll tell you, consent is very important. When patient coming to ICU, na, somebody has to take the consent. This is status, and we need to. What I'm doing in my ICU, I keep the one of the parent in standby. What we are doing, putting cath or this thing, he should know the management. Or after giving one drug, two drug, three drug, because we are manage the patient, and patient should have right to see the everything. But and then patient, we should take the consent. What we are using the multiple drugs, and this is important to save the life. And these drugs sometimes has the side effects also, maybe allergy also. So consent is very important. In my OPD basis, I am taking consent for oxcarbazepine, lamotrigine, and vigabatrin also. Most of the time, I am telling patient I am putting stamp, and the patient having allergy. So this is easy relation with the patient. So taking a consent very important. That is I am saying calm management is very important. We need to tackle the parents also. We need to tackle the staff also, resident also, and manage the patient also simultaneously giving the drugs. Consent is very important.
Sir, after this, there's a question raised.
Matin,
Yes, sir. Please, sir.
Yes, sir.
Dr. Mahesh, one practical question.
Yes.
Now, you said that you keep the one of the parents standby.
Yes, sir. Yes. Yes.
So now I'll tell you the actual problem.
Yes.
If you keep the one of the parents standby, and
Yeah.
when you give the multiple injections,
Yes. Yes. Yes.
even including the boluses,
Yes, sir.
you know what the relative says? डॉक्टर तुमने मेरे बच्चे को इतने इंजेक्शन दिए, इतना
इतने
छोटा सा
injection
बच्चा
दिए।
इतना इंजेक्शन बर्दाश्त करेगा क्या? मार डाला.
हाँ।
I have seen this in a
नहीं,
practical
नहीं.
scenario in
Yes,
most
sir.
of the
Yes,
hospitals.
yes, yes, yes. But sir, we should tackle the parent if parent is educated or non-educated. Most of the happen that parent faint while seeing this. But he should know
Exactly.
the
So that
patient
is
is
also a
still
medical
convulsing.
legal issues.
Yes, yes, legal issues, sir.
When
Most
you
of
dilute and when you
Yes,
inject a
yes.
20
Yes,
ml
yes,
and then
yes.
you give a multiple injection, the practical
Yes,
problem
yes,
is the
yes.
relatives are going to blame you that you have given a lot of injections and which has killed my child.
Nee, but sir, team leader should know that is patient
I think Dr.
convulsion.
Minaj must be facing all these problems day to day.
Sir,
Dr. Minaj.
Sir,
yes.
unmute,
Hinas, sir.
unmute, sir. Unmute.
Sir, you are unmute. Hinas, sir.
Unmute.
Who's not allowed?
Dr.
Yeah,
Minaj,
thank you.
unmute.
I must say thank you. Yeah, I'm muted. Yeah, I'm muted. Yeah. Good evening. At the outset, must say a very practical topic and excellent presentation by Dr. Mahesh. Though it was a pediatric neurological perspective, we are intensivist, but has been excellently, presented. Number one. Number two, with regard to consent in PICU, I must tell you, you must take the consent, but in emergency, the first thing is taking care of children. Number one.
Yes, sir,
At
definitely.
the same time, communication. So there are two different aspects: communication and consent.
Yes.
You need not take the consent for medication, but definitely you will have the communication with regard to what you're talking about.
Yes. Yes.
So I think when the child comes to PICU, we take a general consent, including for procedural medications. That's
Yes.
a general consent, but need not be taking consent for status epilepticus treatment.
Yes. Yes, sir.
That
Yes.
was. But
Yes,
yes,
definitely.
the communication is important. We need to
Yes.
communicate.
Yes. Yes, sir. What is communication? What sir has told, important word is communication.
Yes.
Yes, yes. I'm trying to say communication.
Yeah, communication is important.
Yes, yes. Sir,
Yeah.
what happen after 15
Yeah,
minutes, if convulsion not get stopped,
Yeah.
patient should know that we are also trying, everybody trying, and he required oxygen or other supports also. So he
Yeah.
should see. Yes, yes.
Exactly. That is what I meant. That
Yes,
you
yes.
communicate.
See,
You are
parent-
giving them that
parent
can
these are the
say
drugs
that-
which you have tried. But
Yes,
if
sir.
we make them stand by, that creates
Yes,
a lot
yes,
of
yes.
problems.
That is tricky, sir.
Yes.
That is tricky, you know.
I'll tell you
One.
this, Rambhai, the
Hmm.
concept of this concept of keeping involved the parents in the treatment is important, but
Yes.
we must understand this concept is Western concept,
Yes,
and
sir.
this is different in the Western concept in our context. What Rambhai has been telling is absolutely right, because
Yes.
we need that
Yes.
level of understanding. We
Yes,
cannot
sir.
replicate 100%
Yes,
what
yes.
I have seen. I mean, there are many things we do involve them, but
Yes.
we involve periodically in the sense that in between unko bulana ye kar rahe. If you keep on standing and telling, if you ask them to stand, then as what Rambhai said is a scenario with
In fact, I'll give you one example.
So
One of the senior.
what we do is that we tell them what we have been doing. Yeah, yeah.
Hello.
Please go ahead, Rambhai.
One of the senior
Yeah, please.
pediatrician, he had a patient of a acute gastroenteritis with a severe dehydration, almost collapsed patient. So what he was doing, he was giving bolus that were pushing only IV fluids,
Yeah.
and the relative was standing. After a few hours, maybe 1 or 2 hours, the patient expired. And he literally stabbed the pediatrician saying that you have given so many injections to my child that my child died because of your injection. So these are this is
Yes,
what
sir.
we are treating the illiterate crowd, not the Western
Yes.
countries.
Yes.
Yes.
So I think we
Yes,
have
Matin.
to balance
We
what
should be choosy, I
Rambhai,
think.
what Mahesh sir has said. We
Yes.
have to. Yeah, I agree the same. We have to do the case to case basis.
Yes, yes,
Case
yes.
to case basis.
Yeah, what sir tried to
Yeah.
say practically, we should be simultaneously
But
intelligent.
I don't
If the
think
parent like this, we should manage without parent also.
Yes.
But sir, without parent, patient is dying is again problematic.
No, you inform. We always, what I
Yes,
do is
yes.
practically, and what I advise people that yes, just tell the relative to be
Yes,
the
sir. Yes,
outside of your
definitely, definitely.
PICU.
Yes.
Talk to them, or one person a lot, that every 5 minutes when somebody is giving the
Yeah.
injection, goes
Yeah.
outside that you have given this injection, but there is no response. So now you have changed the medicine, you are giving that, then again there is a no response. So he is updated every 2-3 minutes. They know the conditions,
Yes.
but not in front of them.
Yeah. Okay. Okay.
So, should I proceed, sir, please? There are few
Yes,
more
yes,
questions.
Dr. Mati. Yes.
Yes.
Regarding hyperkinetic movement with the injection levetiracetam. Hyperkinetic movements in respect to injection levetiracetam.
Sorry, levetiracetam. I'm not getting voice.
Regarding hyperkinetic movements in relation to after giving injection levetiracetam.
Okay, okay. Levetiracetam. Okay, levetiracetam. See, in the condition like convulsion, first need to stop the convulsions. Then we can manage the other movement. Levetiracetam itself has the dose-related hyperkinetic movement or psychogenic or the psychiatry involvement also, behavioral issues also. And what is observed, if I crossing more than 35 to 40 milligram, they will develop the some like what you're seeing these moments also or the this. But first, I think very safe drug to stop the convulsions. We can prefer this movement or behavioral changes in comparison with the respiratory distress. I think Minas sir has
Well, I will tell you one
commented
thing
on that.
with regard to status. Now, the most important
Yes,
thing is do not hesitate to escalate your medicine.
yes, yes, yes,
The problem is that the more you are delayed, as
yes,
Mahesh sir has said, the more the refractory it becomes.
yes,
Our problem is we are hesitant to escalate the medications.
yes,
So, you have given first dose of midaz-lores, second dose of midaz-lores, not happening.
yes,
Immediately go to phosphoratine, first
yes,
dose,
yes,
second
yes.
dose, not going, immediately going to valproate or levetiracetam, not doing, straightway go to midazolam infusion. Do not hesitate.
Yes, yes, yes. After 3, 4 drugs also, most
Yeah,
of the intensivists they try to give. This is very important because
yeah,
wasting time and within 1 hour it is irreversible. What is we are saying?
yes,
Always
yes,
intensivist has accepted this. Yes.
yes.
Uh,
So early, I mean, when we say earlier, that means calibrated. Means, I mean, you do not wait for half an hour, then 1
Yes.
hour, then no. Go, and
Yes.
even when you start midazolam infusion also,
Yes.
again, go up, like, not very fast, but at least every 5 minutes. See, you have started from 2 microgram per kg per minute, you can to 4, you can go to 6. I mean, keeping all the things that Mahesh sir has already talked about. But the point is that our problem is we hesitate to escalate.
Yes. Yes.
But
Yes.
yeah, in a good scenario, with a given backup, do not hesitate to escalate, go faster, because if you go delayed, then the chances of going for refractory and super refractory becomes more.
Yes. And midazolam drip is very beautiful drug. What I am saying compared to
Absolutely.
other this thing. Yes.
I mean, in our practice, so Mahesh bhai, we have given up to 16-20 milligram of midazolam. It works
Yes.
very
Yes.
well.
Yes. 20, 24 also we tried. Yes. Yes.
But you have to keep watch on the hemodynamics and
Yes,
ventilation.
yes, 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 yes. Institute. In institute, we can try this.
Two more
Yes.
questions. Hepatic necrosis or Rett syndrome with loading dose of valparin.
Yes. Yeah,
Please
yes.
tell.
Very tricky. But see, race syndromes, then tried, you should know race syndrome. You should know hypoglycemia, this thing. That is, I said while using the sodium valproate, because we learned from this thing when patient coming is not I'm giving first time sodium valproate. Chennai guidelines is the first drug of choice is sodium valproate in the febrile status, but I prefer levetiracetam or fosphenytoin. And till then the time settles, you should know the triads, race syndrome, or we are dealing with something these you can try. But I think Minas sir accept giving one dose is not the bad thing. In
Yes,
the any complicated thing that is related to hepatic enzyme also, single dose
yes.
is not the bad thing.
I
Yes.
agree. I agree. You can give, see, the point
Even
is
in
that,
we give a single dose of mannitol is the not bad thing. Like that, in
agree.
emergency, giving a single dose of 20 milligram sodium valproate is not a bad thing.
I think that's a reasonable answer, because what happens. We understand that we should avoid valproate and hepatic injury.
Yes.
Having said that, if it is been there and the levetiracetam is not there, give it
Give
and
it.
go for the
Yes.
next better
Give
drug.
it. Give it.
Give
Yes.
it. You can give one dose and then you can arrange for the other medication. First thing you should avoid. But you are
Yes.
pushed against the wall, नहीं है, तो don't wait के levetiracetam आएगा और merodoxam नहीं दे रहे हैं और रुका. No, not like that. You
Yes.
can give valproate and then you can at the same time arrange your levetiracetam.
And this is proven by
Okay.
multiple research that pediatric most have the focal injuries. If they present with GTC, but the focal reasons. So these drugs are very beautiful, levetiracetam, this. And then I try to give the sodium valproate.
Yes. Few more questions. Role of intrathecal dexa in status.
Intrathecal
uh,
dexa. I think
ah,
intrathecal dexamethasone don't have any that much
status.
anything.
So intrathecal dexa for what, Mateen?
Sir, intrathecal dexa in
No,
iris. Yes.
Nahin, somebody had
no,
just
no,
asked
no,
this
no.
question in the chat box, that in the role of intrathecal dexa in status
No, no,
epilepticus.
intrathecal dexa, sir, not in status. No, no guidelines has covered this. And intrathecal dexa we are not giving in status.
Okay.
Dexamethasone, it's not anti-epileptic.
Relation of liver pill and ADHD aggravation.
Levetiracetam,
Yes, liver pill and ADHD aggravation. Any
yes, yes. Nee,
Then
see, other than status, definitely, if patient come with the hyperactive children and the fidgeting activity like ADHD or the anything autism with convulsions, I try to don't give the levetiracetam because levetiracetam, oxcarbazepine, they will increase his hyperactivity. If you are increasing the dose more than 25, in those hyperkinetic children, giving up 20 milligrams sometime is the problem. Brivaracetam, levetiracetam, oxcarbazepine, they can increase the hyperactivity. So it can't be a first drug of choice in those children. In status we have to give, that is time this thing. But after maintenance, no, if patient is known case of ADHD, this thing, we try to,
Oh.
I don't want to give the levetiracetam, definitely.
next maintenance drug, what to be preferred?
Next maintenance drugs, what we prefer, sodium valproate, lacosamide.
Okay.
Lacosamide is very good drug, I'll tell you. The
Yes.
sodium valproate also the good, but you keep for enzyme. Sodium valproate, it's a myth that can cause the behavioral changes. Sodium valproate don't cause behavioral changes. Lacosamide don't cause behavioral changes.
In refractory status, the role of high dose injection phenobarbital.
High dose phenobarbital. High dose means you want to give 40 milligrams stat.
Yes.
That
No, not
was, see, I had experience of giving in neonates previously when I was in Mumbai or in government hospital as a trainee. But in private, I don't have daring to give 40 milligram other than neonate. And 20 milligram we give. Sometimes 40 milligram can cause the respiratory problems, and that can create a problem. Isn't it, Minas sir? 40
I think
milligrams
you're right.
sometime,
Phenobarbital,
if
yeah,
we
I
seek
agree
to
with
give
you.
very fast, no, it will be troublesome. High doses.
I think you are right, sir, Mahesh, because phenobarbital is good drug with regard to infancy.
Yes.
Below 1 year, phenobarbital is really good.
Yes.
Above 1 year, there are very set clear protocols. I mean,
Yes,
what
yes.
Dr. Mahesh sir has said is very clear. First, 2 or 3 doses of your benzodiazepine. After that, phosphonatine or phenytoin. After that, your valproate or levetiracetam. And thereafter, all those infusions that we can do. The safest infusion and easiest is midazolam. And if you do all this early, most and after all these things, is some has not to respond, they will be not responding. So they
Yes.
are termed as super refractory status epilepticus. Then all those things comes in, as sir has rightly said, right from ketogenic diet
Yes,
to
yes.
surgery and all those things.
Yes, 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 yes.
any name of intranasal lorazepam? Intranasal lorazepam you mentioned.
Intranasal lorazepam trial has been there. I was there with the respected senior patron sirs or madam, and it was not good in comparison with the midazolam trial. It has taken by one company, and we had a less than 30% result compared with the midazolam. I'll tell you, midazolam result is 52 to 62%. It's not the 100%. So compare with the lorazepam, it is 30%. So this midazolam has evolved, but lorazepam trial in trial.
Okay.
You know, Mateen, what Dr. Mahesh has said in the beginning, the home treatment. If you see
Home
the
treatment.
child convulsing,
Yes.
especially the child who has a known case of seizure disorder now, and if
Yes.
you do first dose of midazolam spray at home,
Yes.
it will work wonder.
Yes.
It
What
will
I
work wonder.
do, yes, I'll
Yeah,
always write
problem is
in my
delayed treatment, delayed
prescription.
intervention.
Yes, 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 yes. I always write in my prescription,
Yes,
10 किलोचे बाळ असेल तर आय राईट 2 स्प्रे प्रत्येक नागपुडीत द्या जर झटके 4-5 मिनिटाच्या पुढे गेले तर आय
yes.
ऑलवेज रीड इन मराठी in any language what patient prefer.
And it is wonderful.
Yes, yes,
It
definitely.
works wonder.
It seizures the status, sir.
It reduces the status.
Yes.
Few more practical questions, sir. Do you send anti-epileptic medication level in every known case of seizures?
See, there are wonderful drugs. This monitoring required I think, mostly for sodium valproate. Other drug monitoring is not that much available. And giving levetiracetam, we know the clinical changes. The levetiracetam is not a bad drug that causing the hepatic injury, that injury. Brivaracetam level is not there, but brivaracetam we need to monitor the liver enzymes also. Brivaracetam some can cause the hepatic problems and renal problems. I experienced once. And the sodium valproate giving the drugs and maintenance is required the monitoring. Why? Cytotoxin CYP inducer. So we need to monitor the drug definitely. Why? Every individual is different. We have experience. 20 kg child sometimes required the doses of the 5 ml BD, or some patient required the 3.5 ml BD of doses. And but definitely you need to this thing. And drug of choice for absence, I experienced one patient only responding to sodium valproate, but after starting sodium valproate his enzyme increases 150 300, and then we did the levels and we tried to put him the lowest this thing, and he surprisingly 13 to 14 milligram per kg he is maintaining the doses. That is sometimes happens. So definitely for sodium valproate I'll prefer monitoring and not the other drugs really.
Okay.
Mahesh sir, I think you know what I personally, I mean, what is the message to be like things this, like any child who is on medication,
Yes.
be it phenytoin or be it sodium valproate,
Yes.
presenting a status, I
Yes.
think it is desirable to get the level done, because there are medications which
Yes.
antagonizes others level.
Even I written in guidelines, possible
Yeah.
असेल तर sir you can go for the level. This is very important.
Yeah. So if the levels are available,
Yes.
especially when it is
In
available,
status is
yeah,
important because this is
it is
compromised patient.
desirable.
Yes.
Yeah,
Yes.
it may not be mandatory,
Yes.
but it is desirable to get the level done if it is available and affordable. Two things are important.
Yes.
Okay. Few more things.
Matin, already 10:30. I think you can wind up.
10:30 हो गया. I think we should stop. I agree with Ram. Bye.
Oh, really sorry for that.
You can take one last question that Levipil वाला वो पूछ ले एक बार.
Yes, exactly, sir.
हाँ.
Which is better drug for maintenance, Brevapil or Levapil?
Means brivaracetam and levetiracetam.
Brevapil or Levapil?
See, brivaracetam we started with very happily. Is the single drug controlling the refractory, and it will be the substituted by the instead of 2 drugs giving 1 drugs. But brivaracetam more than 2.5 milligram develop the psychiatric symptom very quickly in comparison with the levetiracetam. And levetiracetam is very safe to give, calculating if 10 milligram डोज इधर उधर भी हो जाए ना ज्यादा फर्क नहीं पड़ता, बट ब्रिवासेटाम फर्क पड़ता है. So giving the brivaracetam and levetiracetam, always prefer the levetiracetam. In some guidelines brivaracetam using in the status, and but levetiracetam is the very safe drug. Brivaracetam higher doses cause hepatic problems. And what you saying, the hyperkinetic brivaracetam has more problem in comparison with the levetiracetam. Yes.
I think sir has answered very well. Still, I would like to request Dr. President Sir Ramgopal sir, please, if you permit, we can just conclude the session.
No, it's already 10:30. Again, tomorrow we have a Wednesday wisdom, so better to conclude.
Okay, sir. Yes.
Yes.
Sir, Dr. Mahesh Sade sir has excellently answered.
And anyway, we would be sending that PDF file, so that will cover everything.
Yes, sir.
Definitely.
Yes, sir. I'm sending to Matin. Dr.
Definitely.
Matin will circulate to everybody.
Sure. Yes.
Yes,
Okay.
sir.
Yeah,
Yes.
you can
Yes.
wind up, Mati.
Yes.
Thank you so much. Yes. The most important last ending point of vote of thanks. I'd like to thank Dr. Ram Gopal sir for taking the initiative and taking the sessions. I'd like to thank Dr. Amol sir for being a source of energy, always enthusiasm for it. I'd like to thank OBs and EBs for always standing for the help. I'd like to thank our today's expert, Dr. Mahesh Sane sir, and I'd like to thank all the delegates who were patiently listening for long, up to long, still they are listening only. And I'd like to thank Mrs. Pallavi Madam for the Zoom meeting technical support, and Dr. Vishal Rao, digital wizard. Thank you so much for coming, and we'll be meeting again. Okay, thank you so much, and good night.
Thank you. Good
Thank
night.
you.
Thank you, everybody.
Thank you, everyone.
एक कार्ड-
Thank
एक-
Thank you. Good night. Well done. Well done, Dr.